Hello, my name is David Trimberger, and this is my first peer-to-peer attempt at pediatric intubation. First thing that I want to do is gather up all of my materials, such as a suction device. I want to have about a range of a 3.5 to 4.5 ET tube sizes. I want a couple different size laryngoscope blades. I need a BVM, a ET tube with a stylet, some form of stabilization device, and an OPA. So after I've gathered up all my materials, I'm going to come over to my patient, and I'm going to, before I would do any of that, I would also want to make sure that I would put on proper PPE. Going to come over to my patient, and I'm going to manually open up the airway. If I look in the airway and I see blood or secretions, I'm going to go ahead and suction for no longer than 10 seconds, moving in a zigzag motion on my way out. After I have manually opened up the airway and inspect the airway, and I see that it is clear, I'm going to take an OPA, properly measure it, and try not to lose the OPA. Take my OPA, properly measure it, and then I will begin my pre-oxygenation sequence. So I'm going to connect my BVM to oxygen, go ahead, put my patient on a nasal cannula at 6 liters, and connect my patient to an SpO2 monitor. My goal is to try and get their SpO2 to above 94%. My goal is 100, and just to be able to pre-oxygenate them for as long as I can. While my patient is pre-oxygenating, I'm going to go ahead and put them in a sniffing position. So since it is a pediatric patient, I'm going to pad in between their scapula to help try and put their ear to sternal line in a more neutral position. So go ahead, pad behind my patient. Dang it, the OPA fell down again. Take my OPA, remove my OPA. So as I was pre-oxygenating my patient, I would go ahead, be ventilating. I get my patient, their SpO2 above 94%. I will go ahead and begin my intubation procedure. So I will remove that, go ahead and connect my BVM to capnography to help for secondary confirmation. Grab my laryngoscope blade. Come over to my patient. I'm going to displace the tongue, lift up, my lungs are running away from me. Inflate my cuff, immediately remove my syringe, going to remove my stylet, connect my BVM that's connected to capnography, and begin to start ventilating my patient at a rate of 10 to 12 times a minute. I'm also going to do a secondary confirmation by auscultating over both of the lungs as well as the epigastrium to make sure that I have proper placement. So I also have my patient on capnography. After I've confirmed all these, I will continue to ventilate my patient while they're still on the high flow nasal cannula and my BVM is connected to oxygen. Once their SpO2 is high again, I'm going to stabilize my device. So I will go ahead stabilize my device, and then continue to ventilate my patient at a rate of 10 to 12 times a minute. I'm also going to be monitoring their SpO2 levels as well as their EtCO2 levels, and then I'm going to notice for any change in patient condition while en route to the hospital. Thank you.